Can everybody hear me out there? Hello? Hello? Once. Good day, sir. Hello. Once. For technical assistance.
You're all good.
On there. Good heart. I can't hear a word she's saying.
ProStream webcam, that's the one it's supposed to be. It's supposed to be all, I think that we're muted by them right now. I think this is it. I think this was all the right settings. I think that they just don't have us. Yeah.
I hear.
Okay, well, I hope that they can see us.
No.
I tried to do all the settings.
Can't hear a word he's saying.
I mean, we had both Jeff and Gerald in here yesterday, troubleshooting it.
No. I like to know. Can't hear what they're saying.
Well, they may have us muted. We're in the meeting. It says 8 participants.
Just Louis G, can you hear me?
Yes.
Okay.
Okay.
Can you hear?
Okay, can you hear me now?
Yes, we can hear you. Can you hear us?
Yes, I can hear you. I can see you.
Thank you. Perfect.
We can't see you.
No, I have my camera off, so.
Okay.
Thank you.
There, how's that?
Perfect. Thank you. We just wanted to.
Mute my camera.
We were troubleshooting yesterday, so we wanted to make sure it worked this time.
Okay. Can you rename your site to your actual location instead of Lois G?
Oh, do Southeast PACT.
Okay.
Yeah. If you go in the upper right-hand corner, there's 3 little dots. You click on those 3 dots, I think. There's a rename.
Okay, I'm trying to find it.
Or you can right-click on your image. Did that work?
I'm trying to find it. Oh no, now I got out of it. I don't want to mess things up.
Nice and full.
Okay, well, let me do it for you then.
Okay.
And what is your site?
Southeast PACT.
Okay, all right, we got you renamed. Thank you. In the lower left-hand corner, there is it looks like a speaker icon. If you click on that speaker icon, that will mute your site. And we want to keep you
Lower
visible.
left-hand corner.
Okay, I just need to get something done before this starts, and I haven't had a chance. Can somebody else take over for a minute,
Will you last?
please? I'm sorry, I have to get something done.
Okay.
Thank you.
So next person that's up there and running. Okay. All right. In the lower left-hand corner of your screen, Southeast PACT, there's an icon. It looks like a microphone. And if you could click on that microphone,
On the next one.
it's in the lower left corner of all of the images. You move your mouse to the lower left corner.
Oh.
See the little microphone? The little, yeah, the lower left corner of all of the images should be
Where?
Southeast PACT.
We don't see it.
Yeah.
That's not a microphone.
How about, can you right click on your image? Is there a microphone mute?
No.
Oh boy. Just put your mouse on. I'm going to try and mute you from here and unmute you from here.
Okay.
So I'm going to mute you now. And no, it's not going to let me do it. There, you're muted now. I'm going to try and unmute you, and we've got you unmuted. Okay, I'll just run it from this end. And you'll just have to put your hand up so that I can see that you want to talk. Okay? And Lake Watcom, do you want to do a real quick audio test with me? Just so we can make sure that your audio is working.
Can you hear us?
I can. Excellent. Thank you.
Perfect.
And Multicare, do you want to do a quick audio check? You just unmute. Heidi, I see you there. Can you hear me?
Hooray. Hello.
Are you just coming in by phone?
Yes.
Okay.
So the computer I'm on does not have a video webcam anything.
Okay, so which is the connection that, well, okay, if you're coming in by phone, you've got a mute button on your phone.
And then we can see you working.
Sorry, I missed that.
So do you got a mute button on your telephone?
Yes, I do.
Okay, if you would please use that to come to connect and disconnect your audio, that would be much appreciated.
Okay, should I disconnect my audio now or should I wait?
Go ahead and mute it. Do not disconnect, just mute.
Okay.
Okay, and then you can unmute whenever you need to talk.
Hi, this is Crystal with PACT in Spokane.
Okay, do you guys have a mute button on your phone there?
Yes,
Okay. If you could use
I'll
that.
mute it out.
Okay. And looks like Pioneer's there. Kelly MW, if you want to just unmute, we'll do a quick test on your audio. Telly MW. There's a U-shaped table with 5 of you sitting around it. Can you unmute just to do a quick test for us?
Looks like CSMW is live now.
Make sure this is all test. Why are we not?
It's unmuted.
Hey, Jeff.
Hello.
All right. Okay. Good afternoon, everyone. Welcome to our third PACT Echo Clinic. Why don't we go ahead and start this afternoon with some brief introductions of each of your teams. Why don't we start with, it looks like Community Services Northwest. And by the way, before we get started, if those of you, as you're getting ready to introduce yourselves, could follow the instructions that Chris McCain sent yesterday, just to rename yourselves so that it automatically comes up with your team's name. That way everybody knows who each other is, and it's a little easier for us in terms of being able to call on you. So if you scroll down to the bottom of the screen, a little bar should light up at the bottom, and then it should allow you to see on the right side, it'll say participants, and you can look on the right side, yourself listed along with the other participants. And if you hover over the one that is you can actually rename yourselves. So I think Community Services Northwest, I think, is the first team that I see here. And if you guys want, at some point after you introduce yourselves, just rename yourselves on here, that'd be great. Can you guys hear us?
They are still muted.
You're still muted. Can we unmute them? There we go. You're good.
Jason Arnold. Good job.
Liz.
Laurie. Tatiana.
Okay. If anybody from Community Services Northwest in the future, if you guys have like things to say, you might want to come up a little closer, but as long as you guys can hear us, then we're good so far. What about the Wenatchee PACT team?
Yeah.
Hi.
Hi guys, who do we have in the room?
Oh, select a speaker.
Here's.
Here we go.
It's a little hard to hear.
I'm the go-to person in Barb's absence.
Johnson
Program assistant.
Ray?
St. John Book Ed. Gus Goodman, case manager.
Great, you guys, thank you. What about Southeast PACT?
You're unmuted by host.
Hi.
Southeast PAC team is here. We cannot see you, but we can see everyone.
Okay, it looks like you guys are beaming in or something. Welcome, Southeast PACT. Great, and as long as I'm hoping you can hear us at least. What about Lake Welcome Center?
And hello.
Hello. Hi.
Hello.
We're unmuted.
Hi, everybody.
We can hear you.
Cool.
This is Gigi. How are you?
Yeah,
Great,
now we can hear
I
them.
know you can see me, but I'm right here.
And miracles happen if
We're supposed to.
Yeah. Yeah, go around and say hi, everybody.
You guys can say hi real quick.
So, Chelsea, I'm here. Hi. I'm Irene. I'm NHB and NHB.
My name's Rose, and I'm an RN MHP.
I'm Sarah. Hannah, team coordinator.
I'm Rachel, and I'm a clinician.
And Gigi, lead.
And I'm Rita, nurse practitioner.
Great.
That's everybody.
All right, we'll hear more from you guys in a little bit with your case presentation. Thank you. What about multi-care? Let's see, you're unmuted. Maybe we can't hear you at multi-care.
Are they speaking?
Okay, we'll see. Can you guys hear us? You can hear us? Okay, you can hear us. We just can't hear you. So we'll see if we can get you some technical assistance. What about Pioneer Human Services? And I think you just have to unmute yourselves and you can introduce yourselves briefly.
Go ahead.
No, we were muted by the host, but we're here.
Oh, there we go.
Hi, guys.
So
Who
this
do
is
we have?
one of our new nurses.
Hello.
Hello, welcome.
Thank you.
And I'm Tara, I'm the nurse practitioner. We've got Alex here, the social work intern. I don't know if she's in there.
Hello.
And Chris, I think, is on his way back.
Okay, great. Welcome you all. And then let's see, we've got VHR PACT. You guys want to introduce yourselves? We can see you waving.
We don't hear you.
We don't hear you though, unfortunately. There we go.
Now? You go first. Go first. Priscilla. Hi. Priscilla. Claude. I'm Michelle, I'm the team lead. I'm Silva, I'm one of the MHPs. I'm Emily, I'm psychosocial rehab.
I'm Estray, vocational.
Donna, the nurse. That was your long arm.
Hi, great. Good to see all of you guys. And I think we've got a couple teams on the phone, starting with Spokane.
Can you hear us now?
We sure can.
Okay. We still have a little bit of technical difficulty, so you can't see us, but we can see you.
Oh, okay. Well, that's good. Great. Well, I'm sorry we can't see you. Who all do we have in the room?
We've got Colin, clinician, Kyle, peer, Bill, CDP, Leslie, MHP, Craig, vocational. We've got an OT intern, myself, Darren, MHP, and Crystal, team lead, and Tiffany, MHP.
Nice. Thanks, guys.
Cool.
And what about PACT Yakima?
Can you hear me okay?
Yes, we can.
So I'm all by my lonesome here, but I'm Heidi. I'm the therapist MHP on our team.
Oh, great, Heidi. Nice to see you and hear you at least. I know we reached out earlier. Good to be connected with you guys. Hopefully you can get the rest of your
I'm really happy. Yeah, I'm really happy to be involved in the meeting today.
Good. Well, maybe we can get to see you next time. We'll try to work that out in between, okay? So let's
sounds great.
Quick introductions of the rest of our UW team. Why don't we start with you, Jeff? I know you're actually zooming in from another team during a fidelity review.
Yes, this is Jeff Ross Kelly from the University of Washington, coming from Mount Vernon today, where I'm doing a fidelity review. I am the specialist for the revised PACT comprehensive assessment and co-occurring disorders.
Thanks, Jeff. And then let's go to our hub team here. I know Sarah's a little off here. I don't know if we can get her on there.
I don't feel off.
You're not off. You're not off.
Sarah's right here.
There she is. There
Sarah.
she is.
I'm Sarah Kapelovich. I am a clinical psychologist by training here at the University of Washington in the Department of Psychiatry, and I provide consultation on evidence-based psychotherapeutic interventions for people with serious mental illness.
Hi there, Jonathan Beard, LICSW. I provide support to teams in the areas of supported employment and education and psychiatric rehabilitation.
I'm Chris Taku. I'm a fellow at the Injury Prevention Center here at Harborview, and my clinical and research work is all focused on study and prevention of suicide.
And hi, I'm Maria Monroe-Davida. I'm the PACT Echo Clinic Training Director and work with all of you in the PACT teams in Washington State. Glad to be here.
And I'm Chris McCain. I'm a research assistant and Echo Clinic Coordinator.
Great. All right. Well, I think without further ado, since we had a little bit of a prolonged set of introductions here, go ahead and get us started with our didactic for today. Chris DeCoux introduced himself, and I just wanted to kind of preface his didactic this afternoon, just kind of really emphasizing, I think, that Chris is pretty much working with the people, the experts, both nationally and internationally, who are doing this work around suicide prevention, assessment, prevention, treatment. And so that's really kind of where his work is sort of grounded. And so I think I'll turn it over to you, and anything else you want to say about that, Chris?
Thank you. So I, again, work here at Harborview. I spend most of my time doing research. A lot of that's with Kate Comtois, who's really been enmeshed in the world of suicide prevention for a while doing this kind of work. But then I also see patients, medical inpatients, once a week on our consult service. And then I see a couple outpatients during CAMS, which you may have heard of, which is the Collaborative Assessment and Management of Suicidality. And that's working with folks really centered on how do we help people not kill themselves in the future, and making that the explicit focus of therapy for as long as it's front and center for them. And so I've had a lot of experiences related to community mental health. Before I became a psychologist, I was a firefighter, EMT, and police officer, so I saw a lot of how this plays out kind of out in the world, and all the ways that mental health kind of shows up before you end up in a hospital or end up in a clinic. And so that informs a lot of how I think about this now as a psychologist, both in my research and my clinical work. So we'll talk a little bit about facts and figures, kind of the impact of suicide. Most of you will have experienced this to some extent in your clinical work, but then my guess, even if this was just a group of folks we had pulled off the street, is that about half of you would have had someone close to you die by suicide. And if we were to think about how many folks in this group are likely to have known someone who seriously attempted suicide, it would be a large number. And so I'll give some epidemiology kinds of estimates, but want to be really sensitive to the fact that this means a lot to all of us at some level, and that the likely guess is that many of us in this group have been pretty deeply and personally affected by this issue to some extent. We'll talk a little bit about risk factors, because we have to assess those when we do this kind of work, and I want to give you maybe a little bit different way to think about how to integrate and synthesize some of those risk factors. And then just a little bit of an overview of what you can do once you know that someone is suicidal and how it is that they're suicidal to kind of help them reduce their risk. So this is Diego de Leo's definition of suicide, and you'll have all these slides so you can read all the words later. But I just want to center in that last part, that suicide, in addition to being something you do on purpose to kill yourself, it's done for the purpose of bringing about wanted changes. And I want us to carry that as kind of a frame as we're spending some time together this afternoon, that people don't kill themselves for no reasons, people don't hurt themselves on purpose for no reason, that even if it's a mistaken or confused or somehow kind of less than rational kind of reasoning, people do these things for a reason, for a purpose, for some kind of function. And if you understand that, you kind of unlock the door to being able to help someone avoid that kind of outcome. These are terms that you can review later. The big one I'll highlight there that comes up a lot is that we want to kind of think about people as having died by suicide, and sort of avoid the language that we all kind of use, because it's often used where we might talk about someone having a successful suicide, right? Because that we would never think of as a success. And then sometimes there'll be the language of committing suicide, which sort of has that criminal connotation. So died by suicide is sort of what people are using currently. Also, people will say you completed suicide, or that someone has suicided. So in the time we'll visit together this afternoon, many people in the world will have died by suicide on average. About once every 40 seconds in the world, something like 800,000, 850,000 people a year die by suicide worldwide. And I put up this map just to show that even if you started to imagine the different geographic, climatological, cultural regions of the world, that there's quite a bit of diversity in this outcome across different nations. And so there are patterns that tie into many different domains of human experience and even things like geography, but that it's also important to be fairly focused on sort of the national context that you're thinking about for suicidal behavior and death by suicide. And so for that reason, I'm going to kind of zoom in on the United States where we're doing our work. And so about 46,000 people a year die by suicide. The one thing to really point out that's caught a lot of folks' attention is that suicide is now the second leading cause of death among young people. And that's not just young people 19 to 24-year-olds. We could define that like 5 different ways and it would still be true. You could say 10 to 25-year-olds. You could say the 14 to 19-year-olds. Any way that you kind of define this sort of late adolescent, young adult, even middle adolescent age frame, you would see that this is true. And this is very compelling because that's been a new thing that's been observed. Thinking kind of beyond people who die by suicide, which is a relatively rare thing that happens, although far more often than we'd like. There's more than 1 million people who would say they've attempted suicide when you ask them. There's no good numbers for suicide attempt because no one's really keeping track. This is when they ask people, did you attempt suicide in the last year? More than 1 million on average will say yes. And then quite a few more who have seriously thought about killing themselves. Something that is extremely specific to the United States, this is a kind of a US phenomenon, is that it would be fair to say that about half the deaths that occur, half the suicide deaths are firearm deaths. And if we're thinking Washington State, you could say most suicide deaths are firearm deaths. And you could say most firearm deaths are suicides. And that is a really particular kind of thing in the US and something worth thinking about in terms of not just why that might be the case, which could be interesting to think about, but really to think about how does this inform, how does this guide what we would do to help someone not to die by suicide, not to seriously hurt themselves as part of a suicide attempt. So similar to that big pattern I showed you for the world, there's meaningful variation in the United States when we look at suicide rates. I can see it on your faces. You've already seen the pattern, which is that you can tell that kind of more rural, more remote places tend to have these kind of deeper shades of orange, tend to have higher rates of suicide. And that's meaningful even within Washington State because we have a pretty big range of urban kind of and rural communities. Where the more rural your community is, the more likely you are to see an increased rate of death by suicide. And that is also challenging, right? Because often resources are more limited in a rural area. And so you're always kind of working with this tension in how we address risk in places where resources are limited. You probably saw the CDC report that came out. It was all over the news several weeks ago. But suicide rates continue to kind of inch up in the United States. And as has been true since they've been keeping data, men die at a higher rate of suicide than women. You probably have also heard there's kind of a gender paradox here where women tend to attempt at a higher rate than men, with a few meaningful exceptions. So if you look at like prisons, some military contexts, they're a little bit more even. But in general, there's this paradox in suicidal behavior. Looking at Washington, you see a similar trend. So there was some, you could even think about a little bit of a drop, but really since about 2000, there's been a steady increase in the rates of suicide. Certainly not a spike, certainly not like a doubling or a tripling, but inching upwards despite the tremendous efforts that have been made to reduce death by suicide. So there's a mountain of theoretical and academic writing about why people die by suicide, how people die by suicide. I've tried to distill how I think about that into these 4 points, because I think they're the things that I assume about suicide that really guide how I work with patients who are struggling with suicidality, who have disclosed suicidality. And I think these are the assumptions that enable us as providers to really give it our all and really think effectively about these behaviors to try and get in the way of future behaviors. So the first one, which might be novel, I don't know if folks have thought about it this way, but suicide is complex and fearsome. To engage in a suicidal behavior, a lethal self-harming behavior, you have to be able to stare down death in a way that most of us do not have the capacity to do. And that's a real important point, because if you think of it this way, that it is complex, that it takes the ability to really look death in the eye, it kind of leads into that next point that you can't just be that person who can engage in this very fearsome behavior unless you've had experiences over a long period of time. Experiences of physical and psychological pain and provocation is how you might say it. Basically, being able to acquire that capacity takes a lot of time. You could probably think of people in our communities and our society who we really count on to be fearless about death, where it's part of their job. So we are all absolutely thrilled that police officers, firefighters, EMTs, other first responders have fearlessness about death. They are able to manage that fear that makes all of us run out of the building so they can come in and be helpful. You could imagine folks who are in the military, particularly folks who are in kind of a combat role, have to have a certain fearlessness about death. You could think about physicians, particularly emergency department physicians or trauma surgeons as two examples, where they would have to be pretty comfortable being around death, dying, blood, guts, all this kind of stuff. Does anyone have a sense of what all those groups I've been listing have in common? One of the things they have in common? I'm sure there are others. Shout it out if you think about it.
They're all muted.
Oh, they're all muted. Uh-oh. All right. So one thing you might think about, one thing that they all kind of have in common is an elevated rate of death by suicide. It's something that you could look at that's kind of surprising to think about until you think about this core assumption that folks in these professions, folks in these roles get a lot of exposure to death and dying, pain and provocation, and in many ways have been found to acquire a fearlessness about death that's fairly unique. Third point here is that it's not just that people who die by suicide really want to be dead. It is that they have this capacity to do so. And with desire for death, I just want to point out that it's not just someone wants to be dead. Almost always there's also a desire to be alive. And it's this ambivalent process, kind of a push-pull. Last point here, and it's going to really lead into how we think about assessment and intervention. Just for a minute, think with me about house fires. Think with me about how we prevent fires in homes and buildings in our culture. We don't just park fire trucks in front of the houses we suspect are going to be the ones to burn down, right? That would be kind of silly. That probably wouldn't work very well. It wouldn't prevent a lot of house fires. What do? We have smoke detectors, laws and regulations around consumer products to prevent things that might catch on fire, building codes, and we have fire stations, EMS agencies, with very expensive equipment and very highly trained personnel in pretty much every community. Comprehensive approach. If you were to think about then how we might tie that into suicide prevention, it is immensely difficult and not yet known how to predict any individual's ultimate risk of death by suicide, to predict the future. But what we can all do, the thing that we can really give it our all on, is be able to give everyone the best possible care and have a range of things that we do to prevent this outcome. So it's not about predicting the future or knowing what really can't be known for any individual. It's about doing a good assessment so that you give people things that will reduce everyone's risk, even if we can't tell what will happen ultimately. Okay, excellent. So here's the list of risk factors that many of you know. You probably have a list of 13 to 21 or so things in your minds when you think about what you're going to assess. You have to know all of these things, that's true, but the one question to ask yourself, and you can look at these later in the slides, why is it that these risk factors predict a suicidal behavior, death by suicide, pick a suicide-specific outcome? And that why question is helpful in terms of when you think about what you're going to do, how you're going to intervene. And it also is helpful to imagine these things, again, in a process that unfolds over time and in a process that leads to kind of someone's ability to enact something fearsome and complex. These are warning signs. Evidence base for these is admittedly limited, but again, it's a helpful way to kind of think about things that might point towards a little bit more imminent risk. If I had to pick one on here that I think really is one to pay attention to, it's some version of feeling trapped. And if you see that sense of agitation, pressure, I've just got to do something, I feel stuck, I've just got to do something, do anything, I think that's one of those signs, if you had to pick one, that really is worth keying on. So that's where I think people start to enter that state of being able to enact lethal self-harm. So you're going to assess these things. You have to know the answers to all of those things, understand someone's ability to enact a lethal self-harm behavior. Recent standards of care that came out that are really important are these 4 basic things. It's kind of what it boils down to. So one is, does your system have a way to identify people to make sure everyone is being screened at some level in some way, explicitly being asked, have you had thoughts of wanting to hurt or kill yourself? There's got to be some kind of risk stratification. I'll give you a couple tools for that, but I'm just going to put one note in here that there's not a strong evidence base for this predicting outcomes. It's more about helping you think about what interventions have to be brought to bear on what time frame. Again, best possible care, not predicting the future. The one thing to really get in there is a safety plan. I'll show you an example. And then absolutely critical, and the thing that many of you are engaged in, is getting people tied into some kind of regular outpatient care. So here's some goals that you can look at and be thinking about, just to jump right into how you assess some of these things. I put some model questions in. So again, you have to understand someone's desire for death. Do they want to die by suicide? Do they want to die? But then it's also, and there's some domains of that you can have these example questions to help you with. But then it's also this piece. To what extent have you acquired the capability to do this behavior that is very difficult and that most of us would even struggle to think about doing because it is so fearsome? And so these are all the things. Big one here is access to lethal means. We just did a survey of emergency departments in Washington. This only gets assessed about 40% of the time. Huge area for all of us to be thoughtful about, and really saying, do people have access to guns, medications, other dangerous objects, and specifically anything they've mentioned. So you can't assess every dangerous thing in the whole world. That's not possible. You can't insulate someone from every dangerous thing in the whole world. But if your patient tells you, yeah, I've been thinking of killing myself with my CPAP machine, you're going to focus on that, right? Even though you wouldn't ask every patient about if they use a CPAP machine or thought about using one to hurt themselves. But you are going to ask every patient ideally about guns, large stores of medications, and then if ligatures, things they can use to hang themselves, are something that's relevant to them. Painful and provocative events, certainly occupation-related stuff, but also interpersonal violence, any kind of childhood abuse, physical abuse or neglect, any kind of victimization is really going to play into this, where we see higher rates of suicide among trauma survivors. And then again, putting it in patterns over time, and especially relevant for the case we'll discuss in just a minute, using something like chain analysis, which is really explicated in DBT, to get to the molecules of behavior, the smallest little points of decision-making and experience that one by one point towards a suicidal crisis and a suicidal behavior. And we can talk about that more for this case that will be raised. This is just a little decision tree. The punchline here is if someone has attempted suicide before and anything else is going on from your assessment, they're at least in that moderate risk category. They need a detailed safety plan and some kind of follow-up plan. If I had to pick one way to do a very brief assessment, I would get someone to tell me the story of what happened, tell me the story of your suicide attempt, tell me the story of how you got to the hospital or how you got to our clinic. And what you'll find, that feels very open-ended and like it would take a lot more time, and it can. But I think if I were to think about the most efficient way to hit all of these things without a very long structured assessment, this is what I would choose. And we have some wonderful practice-based evidence here at Harborview of being able to get to all these things you need to know by getting someone to tell you the story of what happened. And always chart review, collateral information. If you can get friends and family in there, you got to do that. That is huge, and that helps with all the stuff you need to do to keep someone safe. Here's more questions you can ask that you'll have in the slides. The top 3 things are all free. You can Google them and download them, and I'll also forward the PDFs to you. The bottom 2 things are wonderful gold-plated interventions for suicide, including chronic and severe suicidality. Pretty high burdens of training, consultation, and supervision to implement these. It may not be possible everywhere, so I want to give you both things with an emphasis on free tools like the 3 that are up above. Columbia scale looks like this. There's like 37 different versions. They all boil down to some really wonderful, tangible risk stratification things like this. With yellow, orange, red. Red, you have to do something right now. They can't leave. Orange, you need to make a pretty serious plan about follow-up. Yellow, there might be a concern, but you can be okay with a safety plan and a crisis line number. Safety planning, again, you can read all this later because I want to get into our case. It's not a no suicide contract. It's not a promise that someone may or may not be able to keep. It's a specific series of things so people can recognize risk, respond with their own strategies, talk to other people to get social support, talk to very trusted people who they can talk to about suicide, and then reach out for help with a crisis intervention option like the Crisis Lifeline or 911 if needed. Again, I just kind of put these here in order because you always want to orient people towards things ahead of going to the emergency department, ahead of getting into inpatient psychiatry, help people stay in connection with their lives. This will be very relevant to the case we're going to discuss. Getting people to give up dangerous things is huge because all the reasons people try and kill themselves are complex, overlapping, long-standing, durable patterns of human misery that can be like this big black cloud that takes time to understand, intervene on, mitigate, work on. But if you insulate someone from dangerous things, you occasion all the time you need to deal with this. Insulating someone from dangerous things, getting dangerous things away from someone is something you can do immediately that gives you the space to do all the hard work that takes time, and sometimes a long time, to help someone not feel like killing themselves anymore. Okay, so really tangible point here. If you can, document in your notes VIP. Not everyone needs these things. It's saying that you had a discussion where you talked about the possibility of voluntary inpatient care, the possibility of increased visits, whatever that means in your system, if there's any way you can increase contact with therapeutic resources, and then the possibility of phone consultation, which if you don't do cell phone consultation, which is not possible in many clinics and many systems, you can always give everyone the suicide prevention lifeline. So documenting that you had this conversation is very helpful in terms of managing liability, but also orienting your patients to what is really available and that there's a lot more than maybe they thought of. I'll just leave these as interesting notes to read, and then also just some ideas for when someone is saying they're suicidal to get something that they want or need. It's very difficult. And that the big thing here is really outlining what it is they're trying to get. So we run into it a lot with people want to be in the hospital, so they're not out on the streets. So that's why they say they're suicidal. But you could imagine lots of ways that people might say, I'm suicidal, when they don't actually have an intent to die. And that's something where documentation and being very precise is very important. I'll leave these here as good notes so we can get into the case. 2 other tools to mention. These are publicly funded, so they're free. You can download them with anyone who has a smartphone, which again isn't everyone, but it's a lot of people anymore. On the left side of the slide, it's taking that safety plan and like making it more salient so people can reach out to people by pushing on their face. On the other one is the hope box, and you can actually load in pictures that inspire hope. So pictures of children, pets, family that go up in that middle part. For remind me, they would pop up there. You're going to need to help someone do this, especially someone who's in distress. It's going to take you a session. But once you've got it set up, it's incredible. Distraction or fun little games. Relax me is exactly what it sounds like. And the inspire me are just really cheesy but kind of amazing quotes that I look at sometimes if I'm feeling kind of bad. So this is a good tool, and anyone with a smartphone can access these things, Android and Mac OS. And we ran through that real quick. So email me if you have any questions, anything you want to know more about, email me. We can talk on the phone. I'm available to you.
Thank you, Chris. That was terrific.
I'll say.
I know we had to kind of speed through some of the specifics around safety planning and also documentation and those kinds of things. And so what Chris may or may not know is that we'll probably have him back at some point to really sort of drill down into some of those things with you all too, because we realize 20 minutes is not nearly enough time to go through this very important topic, but we wanted to at least sort of front load these specifics around sort of orienting everyone to the issues. And as Chris said, he did the same presentation to our New Journeys teams, first episode teams in the past, and there are a ton of resources that we will send to you that he'll forward to us that relate to all of these areas too, that you can start working with like sooner rather than later. And then, like I said, we'll try to find a time to get you back in here. I know you're going to have to leave here pretty soon, but we thought at the very least that we could have Chris stay for a little bit of the case presentation, and even if we don't get into specific recommendations, to at least utilize some time, even if it's after this, to embed into our recommendations that we send out to all of you. So without further ado, I want to make sure that we get to our case presentation. And so Lake Whatcom Center, I know you've got a case presentation. Hopefully everyone got the materials summarizing this case, but you know, if you all could just kind of lead with the consultation questions, And then, we'll focus on about 15 minutes of presentation of the client. Again, not necessarily reiterating everything that you sent to all of us, but just giving us kind of a summary of brief history and that, using kind of that format. And then we'll go into some recommendations. And we'll make sure you guys are unmuted as you get started. There you go.
Hi, so we're going to be, just to give you a heads up, we're going to be doing, different people on the team are going to be doing each section. So just so you have a heads up that, we're moving around. But so today we're going to be talking about Eve. And within the past year, she's made significant progress with increasing her insight into the experiences that she has as mental health symptoms. That really started around February 2018 is when she really started increasing insight. Since June, we've seen that she's had also an increase in impulsive behaviors that included 3 suicide attempts since June. So what we've seen is that like there appears to be a cyclical element to her elevated symptoms, which both interrupt progress and increase her suicidality. So our 3 main questions that we have for this clinic today is really looking at what we can do as a PACT team to support her in disrupting this pattern. How can we help her identify cycles so we can all be more proactive? How can we support her in interrupting cycles so she can positively alter her symptom trajectory? And what interventions could be useful for this client?
Eve is a 35-year-old, this is demographics and clinical presentation. Eve is a 35-year-old white heterosexual female with a diagnosis of schizoaffective disorder, bipolar type, and PTSD. Eve was referred to PACT in 2015 following multiple hospitalizations over a short period of time. Prior to her recent hospitalization, she was living alone in a cabin in a ski town and struggled with med compliance due to isolation. She currently lives in a Lake Whatcom Center 2-bedroom apartment with 1 female roommate. Her aunt, Eve, gave birth to a son in 2007 who was put up for adoption. She sometimes lists other births, but these have not been substantiated. Eve expresses Christian-based religious ideology and reports regular communication with both a male and female God. She does not currently attend church regularly, but has in the past. Eve does not currently work or volunteer in the community. Her primary symptoms include persistent auditory and somatic hallucinations, delusions, paranoia, psychosis, nightmares, and frequent changes in sleep. When feeling depressed, she endorses experiencing suicidal ideation. She first attempted suicide at 17 in 2001 when she overdosed on 450 ibuprofen and reported 5 attempts between the age of 20 and 24 years old. Multiple other attempts have been reported. However, timing is difficult to establish due to her being a poor historian. Eve has attempted suicide by overdosing on medications 3 times in the past 4 months, the most recent attempt being in August of this year. She currently sees PACT twice a day for med monitoring because of her recent attempts, and she receives 3 quality contacts per week, which include DBT skill building, therapy, and case management.
So her relevant historical background and psychiatric history, Eve reports a history of childhood sexual and possibly physical abuse, as well as multiple sexual assaults as an adult. She's been reluctant to go into details about events, and we have very little substantiated history from either her or family members. Some of what she reports appears to be delusional, particularly the adult episodes. Her somatic hallucinations and nightmares include extensive rape. Eve reports significant drug use, meth and marijuana primarily, beginning around age 14, and I believe that stopped in her early 20s. for the most part. And she reports occasional use of alcohol at this time. When she was 17, she attempted to overdose after coming off a bad batch of meth when she was up for 5 days. For her aunt, she experienced a psychotic break in 2002 and was diagnosed with schizophrenia, depression, and PTSD around that time. She reports at least 20 overdoses, all of which she has survived. She was the driver in a serious car crash in 2002, which resulted in the loss of her index finger, a broken arm, and significant scarring. And these are things that some of her religious delusions often revolve around. Per Eve and or her aunt, there's an extensive family history of substance use, of schizophrenia, and bipolar disorder. She's been hospitalized multiple times over the years and served by various IOP and case management providers, typically with pretty inconsistent engagement and med compliance.
So based on her putting it together, it seems that a lot of what's been going on recently, at least, is kind of from opening up what we've probably named as Pandora's box and just really not having the skills in order to deal with kind of the re-experiencing of trauma. So she struggles really, really often with like the question of what is reality? What is reality for me? What is real? And having a lot of interpersonal conflicts based on that, because she does have a lot of delusions and hallucinations based on around people she lives with, people she lives near, interactions she has with possibly PACT. So there's a lot of reality testing, but there's also sometimes limited insight into what are delusions. So when she's experiencing these strong negative emotions, she endorses feeling devastation a lot. She seems to spiral really, really quickly. So a pattern we've noticed is that she'll go from saying one day she's really happy and she's feeling like she's made so much progress to the next day feeling like I'm so devastated, I don't know what to do for myself, and kind of spending all day in bed and not really wanting to engage with us. So she flip-flops pretty quickly, and it's a pattern that we've continually noticed. So her reason for suicide, and especially with ODing on her meds, she's endorsed as not really wanting to die necessarily, but wanting to no longer suffer. So we think that's a pretty big indicator of how she's been feeling lately. And yeah, so we've come up with quite a few different things in the past month, especially for different interventions that we've been trying. So those include some DBT skill work that we've just begun. I'm doing it with her actually, and we just began with mindfulness, and we're trying to do it weekly. However, her engagement is up and down.
We changed her medications to an injectable, which she likes, every 2 weeks with little Consta, and that kind of, she's on a bunch of other medications, but at least one of them is consistent, and the nurses, I think, are able to keep the injections up to date. What's the other one?
Yeah, we're doing counseling with her weekly, and we've shifted the focus of that. Initially, she's spending a lot of time talking about the sort of her perception of a lot of religious ideosity, and not really getting into any of the historical abuse, but it started to become apparent that she's really, the content was becoming overwhelming, and so we've really shifted the focus back to process and trying to keep a bigger picture, trying to tie in the DBT skills and other coping skills to help her keep her basically emotionally regulate. We've got a RAP plan from our peers can do a RAP plan with her soon. Just really trying to build up her skills so that we can kind of slow this process down, identify some of the cycles and be more proactive about it, and basically help her find things that she can do along the way so that we don't keep ending up with the same trajectory of her taking all the meds that she can find. Because one of these times she might actually be more successful than she has.
Another thing that I've heard you talk about before is like help supporting her in finding purpose in gardening. Yeah. So in more daily activities, she's mentioned like not really being at this time thinking that like a full-time job is something that she wants, but looking into gardening around her apartment complex, coordinating with the property managers there to see if that's something that she can do on a more regular basis. And also just understanding that like when her house plants, it's been inconsistent. Like she'll be really engaged and find a lot of purpose and then kind of pull back from it. And on days where she's feeling more hopeless and more defeated. So that's a really inconsistent participation in that as well. But she's mentioned that that's something that is important and she finds purpose in her plants.
And also connection. I mean, she's described feeling really isolated. And so, there's been talk about maybe, her going to like a NONI support group. We haven't quite, hasn't quite come to pass yet. But that's another piece of it is just how to feel connected to other people and how to have some purpose in life.
She has expressed struggling being in a public setting because of her delusions and not knowing what's real and being afraid of saying or doing something odd that she might be judged for. So when she's talked about like she's mentioned volunteering, but she wants to do a job where she's isolated and doesn't have to interact with other people.
I'm going to go ahead and I don't know if you guys are done yet, but you guys did a fantastic job, first of all, of presenting this client. I think we all have a really good sense of who she is, and fantastic job of the work that you've done so far. I mean, I know she sounds really challenging and it's a scary situation, especially more recently. In terms of process, we're going to do something a little bit different today because I know, so we do have 4 minutes, believe it or not, before you have to leave. But I just wanted to make sure we leverage some of Chris's time before he has to head out the door to another meeting, just to see if there's anything that sort of, you either wanted to ask questions about or considerations for folks. You want to? And
I can cheat a few minutes past.
Okay.
Tremendous work. You're helping this person be connected to all the things that she's going to need to be successful. And I think I heard it in what you were saying, even though you didn't say it explicitly, but you've embraced that key DBT principle. If everyone thinks back to their DBT worksheets and assumptions of skills training, which is the first one, that everyone does the best they can with the skills they have and needs to do more, better, different to relieve suffering, right? The primary dialectic. And so I think all the ways that you do and continue to praise for her and support her, that you do the best you can with what you've got. That's true. And there's some other stuff we can try as well. And in that spirit, to just bring along maybe a couple other interventions that just jump to mind. So I'm kind of fixated because this is what I think about on the overdose behavior. That's just kind of suicide research. That doesn't have to be everything you do for this person. But I really think and it takes time to understand how it is that she comes to take all these pills, and to take that word impulsive and kind of hold it in your thinking and sort of imagine, as impulsive as a suicide attempt with pills could be, just think of what you actually have to do to take pills, and to take more than one, and to take 40, I think was something I saw in a note. This is a tremendous amount of behavior. Like if you just imagine how quickly you could do this if you really focused on it, it's quite a span of time. It might even be minutes. And this is really a significant amount of time to kind of hook someone into the interventions that we have, whether that's DBT skills. So my favorite set of skills that jump to mind here are the skills where, as part of emotion reg, where if you have an intense emotion, you do an intense physical thing to counteract it. For many people who benefit from DBT skills, that means I cut myself. That's not going to work for a lot of reasons, right? It's not a very effective strategy long-term. So we encourage people to run up the stairs really quickly if they're able. Dunk your face in ice water if you have the ability to do that, or hold, a cold pack on your face. Do things to counteract it that are very tangible. But I think even before getting to skills, I think where I might be tempted to focus is to really get molecular about how she gets to the point of taking the pills. And to such an extent that start wherever she's comfortable describing the behavior, And then usually it's some version of, and then I took all the pills. Oh, I see. I'm assuming you had them in your hand when you took them. Well, yeah. Oh, okay. How many? Well, like 2. Oh, I see. And you took 40, so then 2. So you took 2 pills 20 times in a row? And then you can see where I'm going with this. If you feel frustrated by the routine, you're doing it right. That's the idea. It should be an agonizing level of detail. And again, it is the molecules. It is the littlest bits. The reason is, if you do this with someone, I think you'll be really, I'm always very surprised. When you scaffold in this way, the thought, the cue, the trigger for the suicidal crisis will usually become apparent. And that's the point of intervention. And you also orient your client to the fact that no one really just does anything. Even the most impulsive behavior has quite a few steps. There's my bold statement there. Just to say that there's a whole bunch of places where she can learn to intervene and to interrupt the sequence. And so I would be pretty fixated on that specific behavior as kind of the, again, thinking to my DBT list, self-directed violence is always number 1 until there's not any more of that. And then one way to do this, and you'll get the resources with the email after today, is with Barbara Stanley has a wonderful safety planning intervention that's free. And it's just a worksheet. But the idea is using that chain analysis, that really detailed investigation of the behavior, to figure out what are the situations and maybe even the thoughts or the cues that trigger this sequence of behavior, and then work together on paralleling it with, well, you know, it's when I'm home and my neighbor comes home every night about the same night and slams the door really loud, and that creates this anxiety feeling. And then it's stuff like that that you don't know until you do this detailed analysis, and then that becomes the top of your safety plan. Where there might be things like that you discover that we just, you may know some of them, but are hard to know until you really engage in that, which is challenging. It's aversive. It's quite punishing a lot of times to get into that level of detail. But it can really help save someone's life in terms of being able to draw out the pieces that are hard to notice without this procedure. Another thought I had as we do the fire hose approach here was just, I think it's really okay to be frank with people about what is true, which is someone can always kill themselves later. That's a choice everyone has for the rest of their lives. All of us have that choice that we'll have to keep making to some extent. And along with that, to help orient to someone that there's no rush for such an important decision, and to help orient someone back to the fact that, and right along with the DBT approach, you can choose to endure, you can choose to accept quite a few things for a while to give yourself the opportunity to solve some of these challenges. And it's okay to be honest with someone that things might be truly horrible right now and seem intolerable. And that it's okay to kind of acknowledge that suicide will be an option in the future, as it will be for everyone. But you might choose to avoid it for now to work on this. And if you can't choose to avoid it, how can we work together? It's kind of the punchline of that maneuver. Where it really is just being frank with someone, if you kill yourself, we can't work together anymore. So if you read Marcia's book, she has a line in there that's kind of a famous line. There is no psychotherapy that is known to be effective for a dead person. And it's okay to be honest with patients and clients about this issue, that I need you to stay alive long enough. How long are you willing to put self-harm, suicide behavior on the table? You can always come back to later. If that really is the best course of action, if that really is the best decision, which I don't think it is, it will always be there. But if you make that decision now, we can't do all this important work. We won't have the opportunity to work on this important decision together.
Thank you. I know we extended your time, so.
Any questions in 2 minutes?
Yeah.
Sorry.
I guess I'm imagining having the conversation with her, that chain analysis, and I'm imagining getting some resistance in terms of not wanting to drill down, basically, I don't want to talk about this right now. I just want to go lay down. I'm really tired. Goodbye. That would self-trigger her. Yeah.
So that's one that is just worth, I think, rolling with the resistance to the extent you can there, because this person better than any of us, and managing that as best you can. Some metaphors I find helpful for addressing this issue of that's too much to think about in terms of, or that's, you know, that's overwhelming to get into this level of detail, is to just also kind of illustrate for someone how overwhelming it is to think about a suicidal behavior as, and then I just try and kill myself. It is overwhelming to think about preventing that behavior. If you truly, impulsively, without thinking, try and kill yourself, that's terrifying. Because how do you prevent a behavior that happens with no forethought, with no steps?
Ms. Gigi, what are your thoughts on personality disorders? I know I broached this topic because I like to clinically rule things out, but there's the thought that it's not personality disorder. What, based on what you've heard so far, can you lend us some insight onto your thought about that?
So I'm gonna punt a little bit and then I'm gonna run away. So, but just for me, when I think about how PDs fit into these behaviors, these types of behaviors, I think for me it's helpful to think about personality disorder, the phrase that we're given from the DSM, as durable patterns of thought and behavior that emerge over time and are so long-standing and so ingrained that they take on this quality that we would call them characterological, dispositional. That's how you are. But I try and think of it as their sequences of thoughts and behaviors that take on a life of their own. But I'm always trying to see if we can draw out together, when I work with someone in session, the ways that it's not immutable, it's not some inherent piece of them, it's a sequence of things that we can understand. And when we sequence things, even something as durable as a personality disorder, symptoms of PD, it gives us all the places we can intervene and we can kind of cut that sequence, which is a little bit of an unsatisfying explanation. And I'm going to run away now.
She doesn't have that in her diagnosis. So this is just something I've broached the topic of.
We can talk amongst ourselves. Appreciate
That's
it.
right.
Thank you, Chris.
So much. Thanks for coming, Chris. This is
And
great.
we'll still continue with recommendations. Again, we did this a little bit out of order in terms of getting recommendations. I want to kind of turn it back to the rest of the teams in terms of any thoughts that you all have about this client, any recommendations that you want to share with the Lake Whatcom Center team? Any clients that you've worked with similarly that you want to share kind of how that worked for you, or what, or considerations for the future? Just remember to unmute yourself. We acknowledge it's a tough set of questions, so you wouldn't be presenting if it wasn't. Or any questions you have for the team. That's another thing, because again, we had to kind of short shrift the clarifying questions and then the recommendations. But any questions you wanted to ask the team to kind of further elucidate. Multicare, did you have something? I know we couldn't hear you guys earlier, so, and we're not hearing you now. No? No, okay. You can also call in if you need to.
I'll send you the number.
Okay. Randy's going to send you the number if you guys want to ask a question or weigh in. I'm going to come back to our group, and I'm realizing, just in the interest of time, we've got basically 3 questions on the table here related to supporting her and disrupting this pattern. Thoughts from our team in terms of how we can support her, help her identify cycles so we can all be more proactive, and how can we support her in interrupting those cycles? I think those two kind of go hand in hand, so maybe that one first.
So I have a few thoughts that I want to share, and I took some notes, so forgive me if I'll be referring to them from time to time. First of all, I want to thank you guys for bringing this client to the ECHO, because this is just a great opportunity to talk about a really challenging case that has a lot of the components that our teams across the state are working with. We know that PTSD diagnoses in individuals with SMI, the prevalence is 35% as compared to 2% in the general population. So PTSD is underdiagnosed, but even among those who have a diagnosis, we still are seeing really high comorbidity rates. And then they lead to all sorts of additional challenges in terms of their lives and in terms of our treatment. you know, we know that there's a reciprocal effect between PTSD symptoms and then other kinds of psychiatric symptoms. So the PTSD symptoms are amplifying anxiety, mood, and psychotic symptoms, and our anxiety, mood, and psychotic symptoms are making the PTSD symptoms worse. So not surprisingly, as a result of that, we see high rates of substance use disorders and medical problems and all sorts of things. So important that we're talking about this in a really tangible, concrete way by talking about Eve. So thank you for that. I think, you know, in thinking about how to help her identify cycles, I agree with Chris completely in terms of the utility of doing a chain analysis with her, and it may not be over one session, given what you had noted, that you're anticipating some resistance to that process. And I think, you know, we, as clinicians, we want to, you know, make things non-aversive for our clients, particularly when their lives involve a lot of suffering already. And yet we know that at the same time, some of our most effective interventions can be a little aversive for our clients. So exposure-based therapies are really challenging for folks. These chain analyses, which is a kind of exposure, are really challenging for folks to tolerate. And so we have to kind of find that balance between doing an intervention that's going to be challenging for the client and for us to do, and also making sure that people are comfortable enough in the room to be able to tolerate that. So I would recommend starting, if you haven't already covered, really just some good quality psychoeducation on trauma and on PTSD and on the treatments for those, because one, I don't know that, you know, you've had her for 3 years on the team, so maybe this has been covered, but I think embedded within psychoeducation is normalization, right? It's this idea that what you're experiencing not only makes sense given what you've gone through, but a lot of other people are experiencing it too. So when I was listening to you and looking at the materials, I counted 4 different domains of types of trauma. People who have 5 or more different types of trauma in their past are at a 25-fold risk for developing psychosis, which is, you know, nothing's a guarantee in life, but 25-fold that's pretty dang high, right? So it makes complete sense that she has difficulty understanding what's reality-based and what's not, that she would feel things and hear things that other people don't hear. It's exactly what we would expect given the amount of trauma that she has endured. And so we want to start with that kind of normalization and then provide hope, right? And we know that actually there are some things that we can do that might push you initially outside of your comfort zone, but will lead to reducing that suffering, which is our ultimate goal. I would start, after you've done that psychoeducation, with tracking. So in DBT, as you guys know, this is done through the diary card. You already are at such a head start here because you guys know so much about her already. You might have some really good hypotheses about what needs to go on that diary card. So you already mentioned the feeling of devastation, which is, I'll get to that in a second. But, you know, is it shame? Is it hopelessness? Is it helplessness? You know, you want to get at urges to suicide. All of that goes in the diary card so you can get some more nuanced understanding of how these things are fluctuating each day for her. And then I would think about going with the chain analysis for that August attempt. And the one thing that I will add that Chris didn't mention is making sure that you are not ending with the attempt, but you're going beyond that, because when you go beyond that event, then you can see, are there things that are reinforcing that behavior that you weren't accounting for? Like, is the team rushing in and she's feeling loved, right? Is it a hospitalization experience that's making her feel, you know, safe? And then you want to look for ways that you can meet those needs before she's, you know, when she's not attempting suicide, right? So really kind of try to work upstream and prevent that. And then reinforce like hell when she's using strategies that are more effective, right? That are non-suicidal. We're making sure that if she's calling you, that you are just really, like, even bringing it up as an accolade in front of her to other staff members. Do you believe Eve was in distress and she called me and I was so proud of her, because I know that is so hard to do, and she did it, man. That is so great. And then, sorry, no. Oh, I just want to say a word about devastation. So when we think about how we can use DBT skills, and I'm so happy to hear that you guys are, it's exactly what I would recommend. So fantastic that you guys are 10 steps ahead of us. The kind of first skill here, I think, for her is really being able to identify distressing emotions at lower levels, because when you're at 9 or 10, that space between the thought and the urge and the behavior, it's like nil. So we want her to get more attuned to lower levels of emotional distress and like affective labeling. When I feel, shame in my body in this way, and at a 1 it feels like this, and at a 5 it feels like this, and at an 8 it feels like this, so that she can be more sensitive to that. Devastation is sadness at a 10, right? So that's what she is attuned to, and that tells me we need to get her to be attuned to sadness at these lower levels. And then you create coping cards. So when I'm feeling sad at a 3, these are the 3, 4, 5 things that I'm going to do. This is my sadness 1 to 4 scale coping card. And this is my sadness 5 to 7 coping card. And if I'm at an 8 or above on sadness, then these are the things that I'm going to do, and it's going to include a crisis management plan there.
Excellent. Yeah, that's great. It's a lot of stuff. Thank you. Anything else related to the first 2 questions before we finalize the last one, and then any other questions folks have today?
I'll echo a little bit of what Sarah was saying. Helping Eve to identify like that first barely perceptible, signpost or landmark of heading down that road again, and doing some work around that. It's I guess another version or another way of talking about the chain analysis, because if we can get to that sort of molecular component, to borrow from what Chris was saying, then I think you can also begin to say, well, what could you do differently at that first signpost, that first landmark? Is there something that could be done to distract or to divert? Chris talking about running up and down the stairs as an example, could be something that could be helpful. So I did want to sort of just echo that. The other thing I was wondering about, and this popped up in a couple of places with the information that you forwarded, impulsivity is mentioned numerous times. And I'm not a prescriber, but I've worked with prescribers throughout my career. And sometimes when there's a lot of impulsivity, there's some consideration given to the use of a mood stabilizer. And I don't know if that's come up in the prescriber's work with Eve, but I would ask about that. I would wonder about that.
Great.
Oh, I think she's trying to.
Yeah, go ahead.
She's trying pretty much everything under the sun, and the one that she responds most well to would be risperidone. And the same thing, the other thing to consider is that she stopped taking her medications, the oral ones, so we can never predict, even if she was on the best mood stabilizer on earth, we can never predict whether she's going to take it or not. Okay. As a result, she's on an injection, and then the team goes daily to help her out and make sure that to their best extent she's not piling the medication. So she's been on everything possible, but we're still having some hard time.
Can I segue into that?
Yeah, go for it.
So a couple of things that I saw on the medications that she was taking is that she's got a PRN of diazepam and also a PRN of gabapentin, right?
Mm-hmm.
So have you noticed recently any changes in how she's taking those medications? Is she taking more, taking less? Has there been any noticeable change in how she's using those medications?
She had been taking them, she had them in her possession at one point, but I feel like from like 5 months ago, she's taking less of them because she doesn't feel like they work. She talks about her anxiety building up over days, and that the gabapentin doesn't help that. And then the Valium, she doesn't take very often. And the dose had started at a lower dose, and it was like 5 milligrams, and then it was 7.7 milligrams, and then it was 10, in an attempt to help treat that anxiety she gets. But she's voiced to me that the Valium doesn't help either, so she rarely takes it.
Okay. So I also saw that she had trouble metabolizing, that she took the CY, whatever that test is. I can't remember it off the top of my head, but that she's got trouble metabolizing. She's probably got an even more elevated level of that particular medication if she's even taking it semi-regularly, because diazepam has a pretty long half-life. So what's that?
She's only taking maybe one a week, and we observe because we're afraid she'll stockpile them. And then
Yeah, right. And that's the other thing with that drug, is that they're not dangerous in and of themselves, but they are extremely dangerous along with other depressants like alcohol or opioids. They're particularly dangerous that way. So definitely want to consider the lethality of that particular medication. But because both gabapentin and benzodiazepines work on the glutamate GABA neurotransmitters, and those neurotransmitters are also involved with PTSD, so that they're already dysregulated. You can get a lot of dysregulation actually through that particular medication, and they're not even being prescribed by the armed services anymore because of that particular reason, that has a tendency to aggravate an already dysregulated system with the glutamate and the GABA. So just something to keep in mind.
I have one other thought, particularly circling back to my distract and divert. Some sort of meaningful activity, whether it's work, school, volunteering. And I understand some of the fears that she was expressing around, some of her symptoms getting in the way and doing something in public that could cause her embarrassment or shame. A second thing that could be brought to bear on that would be some psychiatric rehabilitation services in the form of some social skills training to help boost confidence, and then to support her with selecting one or more places out in the community where she could go out and actually practice those skills. So some combination of the two could be helpful with the distract and divert, or even, maybe more sort of on a basic standpoint, just give her something else to do than to be alone and preoccupied with her symptoms.
Mm-hmm. Yeah, and I think that's a nice segue into the last consultation question about what kinds of interventions that we would recommend. I mean, what I'm hearing obviously is that DBT is going to be a great vehicle to continue with, and Sarah had some really terrific specific examples, as did Chris, related to kind of moving forward with that. One thing I would highlight and to pair with that too, is you mentioned that your peer is potentially going to start to work with Eve and potentially doing RAP. And one other sort of component that I think also fits with what Jonathan said that can kind of ease into some psychiatric rehabilitation, particularly around social skills training, is IMR. And using some kind of what I would call targeted IMR, not going through the whole deal because there's a lot going on already and we don't want to overwhelm her and have things working at cross purposes and that kind of thing. But at the same time, I think having something grounded in her goals as sort of the sort of crux of all of this, and really kind of working within a couple of the modules more specifically in a more targeted way, maybe one way that the peer could also work. So there is, a module on developing a relapse prevention plan, for example, that would be part of what you would be doing with RAP anyway. Also coping with stress and coping with debilitating symptoms, and then building social support, which is kind of a mini sort of version of social skills training that kind of gets some of those skills on board and helps to kind of build in, again, her own ways of sort of coping, and at the same time grounded in her goal, that I also think can pair along with sort of the work that you guys are doing within DBT. So not overwhelming her. I mean, I think it can be done in a way that doesn't feel like it's like overly manualized. Again, I'm thinking targeted IMR in this case. Other thoughts from either, I guess I'll just open it up, our team or the other teams as you're thinking about this case, thinking about the work that they've been doing with Eve, that you'd like to make recommendations on? No, there's a lot there. Somebody's trying to, which team?
Community Services Northwest.
Community Services Northwest, did you guys have, were you gonna bring something up? No? Okay, right. Okay, well, I think that concludes our case presentation and recommendations. And as we've done in the last couple of ECHO clinics, we'll send around the recommendations in summary, as well as the didactics and the tools that Chris mentioned that I think also kind of pair nicely with this particular case presentation. Just for the record, it was sort of serendipitous that we happened to have a didactic today that also happened to sort of, and a case presentation that happened to focus on suicidality. That doesn't usually happen that way. So we had kind of the benefit of having someone sort of in our midst related to that. But that said, I did want to bring up our next our next didactic for next month, which is Jen Gottlieb, who will be joining us from Boston and presenting on trauma and PTSD within PACT. Not necessarily focusing on the PACT side of it, but more kind of illustrating and going, you know, kind of building on a lot of what Sarah was talking about today around prevalence, but also sort of, you know, risk factors and things to think about, and how do we sort of work with trauma with people who are experiencing psychosis. So as you all think about clients, you know, that you might, you know, a team that wants to present next month, it might be a nice opportunity to bring up a client that, you know, is experiencing trauma or PTSD that we might be able to leverage some of Jen's time on that call, which again, hasn't typically happened, but might be a kind of a nice serendipitous thing. Other consultation questions that other teams have, whether clinical or programmatic, or questions that you have, you know, for us in terms of anything related to PACT. It's like rush to the finish line here today, and then we've got a few minutes left.
Hey, I did want to say that that was a really terrific summary of assessment and putting it together that the Lake Watkins Center team did. Yeah. I was really impressed by that. Yeah, good work.
Well, and I feel like it really, you know, helped us to sort of see her. She became multifaceted. Sort of kind of jumped off the paper, which is sort of the hope here, that it's not sort of this sort of flat, you know, assessment, not knowing her really, but I feel like we got a really good sense of who she is based on what you had in their words, but also how you, you know, pulled in more information through your case presentation. So thank you so much for the hard work that you guys did in that respect, for sure. And the hard work you're doing with her. Terrific job. In terms of next steps, so we will be, we've got a training team meeting here that will be pulling from our team leader retreat recommendations that will focus on sort of, you know, what does our year look like, both in terms of training that we'll be offering, but also in terms of our future ECHO clinics. So our goal will be to sort of flesh out a number of months, the better part of the year really, of what each didactic will be, so that you guys can also plan in advance to kind of know what kinds of didactics are coming your way and how that might fit with, you know, particular clients you're working with. And I would say, you know, where we can, again, do something similar to what we did today, where we were able to leverage experts in those particular domains and have them, you know, be part of our consultation call, that would be great. We can't always anticipate those, but where we can, we really try to do that. So I think that kind of leads me to our next case presentation. If any teams want to volunteer to present next month, our next ECHO clinic is on Wednesday, November 14th at the same time, 12 to 1:30. Again, the didactic will be focusing on PTSD and trauma with people with psychotic symptoms within PACT teams. Any volunteers? Anyone who wants to, has a client they're really having a tough time with, they want to have some assistance with?
Yeah, get some help.
And it doesn't have to be, you know, related to PTSD and trauma.
This is Heidi from PACT Team Yakima.
Yes.
I can do that. I can do that presentation. I'm not sure which client I want to pick. There are a couple that I'm thinking on, but I would like to, yeah.
Sure, and we're happy to help you if you want to consult on kind of which one. We'll make sure, Heidi, to also work with you on ensuring we can see you the next time around then too. So
yeah.
We'll get in touch with you so that we can have it, you see us and we see you as well. That's great. Thank you so much. And if there is an opportunity to get more members of your team on board, especially those that are more actively working with the client you select, that would be terrific.
Yeah, I want to try to work something out. We have our staffings right around this time, and so I think that's why it's been difficult for us to get the whole team on board. But I do think it would be beneficial for everyone.
That'd be great, even if it was for the one that you guys present on.
Yeah.
We know it's hard for you guys to reserve the time in your schedule, so we really appreciate all the time that all of you have been taking to be on these calls. Guess in parting, the other thing that we'll be sorting out as a training team is just figuring out the best way to get your feedback going forward. In the past, we had done this poll everywhere at the end of our echo clinics and some of our other echo clinics, and I really want to make sure that we can have a process that is not overly burdensome for you all after every echo clinic, and at the same time allows us to gather information from you all in terms of what were the kind of strengths and what were areas that you would like to see, that we could have done differently, as well as identifying ongoing training topics. So that's the other thing. Well, as you all present different clients for each echo clinic, that also helps us to say, boy, there's a trend here. We should really focus on this with future didactics. I think even spontaneously, but also in a more methodical way, we want to make sure that we get your feedback on future echo clinic training topics as well. So we'll keep you posted on that within our next echo clinic. All right. Well, it seems that we've kind of reached a natural ending. So thank you all for taking the time today, and we'll see you guys on November 14th, if not before. Bye.
Bye all.
Bye.
Hey, I've got to take off here pretty soon and get back to the. You guys are muted. What's that?
Oh, we're muted. Anything you want to share in your last minutes?
No, other than I just think this is going really well. I'm so pleased.
They did a fantastic job, man. Aren't you pretty excited? This is a team in your backyard now. You could
Yeah, it was a terrific case presentation, really super relevant to everybody else.